this is the concluding part of the 3-part series lecture on oral manifestation of systemic diseases, and I am Dr. Lahari Telang here. So today we'll be talking about corticosteroid therapy. Corticosteroids are the mainstream of treatment for a lot of diseases and considered as one of the wonder drugs and have a very good anti-inflammatory potential. So they are essential part of the body response to stress like trauma, infection, and during a stressful operation, for example in general anesthesia. And increased stress will lead to increased corticosteroid response. So that is the hypothalamic pituitary and adrenocortical axis, HPA axis, which you are familiar with already. So in patients receiving exogenous steroids, that means other than the one that the body already produces, patients are sometimes given external steroids as a response for treatment of many diseases. So what happens is that this pituitary hypothalamus axis in patients who are receiving exogenous steroids is generally suppressed. So there is no enhanced corticosteroid response that follows when there is a stressful event. So what happens is supplementation of corticosteroid before and during periods of stress should be done. Let me explain this to you again clearly. The body essentially produces corticosteroids, which is produced by the adrenal cortex. But in some patients who are suffering from diseases, for example, pemphigus or arthritis or other autoimmune disorders, this own self-produced corticosteroid is not enough to combat the problem that the body is facing. So, treatment in the form of external steroids has to be given to the patient. So what happens in this kind of a situation is the normal production of body steroids, which is already not enough, gets suppressed further. So if you're having an unprecedented stressful episode, then the amount of steroid that is being produced by the body plus the steroid that the patient is taking daily is not enough to combat that stress, and hence more amount of steroid may need to be given to the patient. So here are some examples of systemic corticosteroid therapy. That means when are patients generally given steroids? For example, long-term corticosteroids are used for suppressing inflammation, like in asthma, SLE, pemphigus, or for immune suppression. Patient is already having an immune suppressive disorders like ulcerative colitis, Crohn's disease, or in case of organ transplant. And also in patients who have missing hormones to replace these hormones, for example, Addison's disease. So if you were to look at this table here, it's a very interesting table which shows you the approximate potency of steroids relative to hydrocortisone. If the potency of hydrocortisone is considered as 1, then in this case, let us look at some examples of short-acting steroids, like for example, methylprednisolone, whose potency would be equal to 5. That means it's 5 times that of the potency of hydrocortisone. So I hope you understand what is the term potency over here. Potency, in other words, means strength of the steroid. Prednisolone would be 4 and prednisone also would be 4. Medium-acting steroid, for example, triamcinolone is 5, and long-acting steroids, betamethasone is 25 and dexamethasone is 30. So you would see that the long-acting steroids here have a lot more potency than the shorter or the medium-acting ones. So let's look at a case here. A 67-year-old female patient comes to your dental clinic complaining of painful lower front teeth. On examination, you notice that her lower anteriors are mobile and require extraction. Her medical history revealed that she was suffering from pemphigus and was on long-term systemic steroids. Currently, her blood pressure and blood glucose level are under control with medication. Plan her treatment, dental treatment. So, if you were to look at dental treatment of patient who's on steroid therapy, first of all, this table again is complex yet very important to understand. If you are looking at dental treatment, which is conservative dentistry or dentoalveolar surgery under local anesthesia, example a single tooth extraction. So a patient with no steroids for the previous 12 months, that means someone who's not been on systemic steroids, there is no need to change any treatment, the way you're doing treatment. Whereas for a patient who's been taking steroids anytime in the past 12-month period, give the usual oral steroid dose in the morning which the patient has been taking, or you give an injection of hydrocortisone 25 to 50 milligrams IV just before the procedure. And of course, it's important to monitor blood pressure. If the patient is currently on steroids, currently taking steroids for some disease process, and you have a stressful episode, dental appointment like a simple extraction or a root canal treatment, it's important to double the oral steroid in the morning that the patient has been taking. For example, if the patient is generally taking prednisolone 30 milligrams every day, so that morning you will have to ask the patient to take a 60 milligram prednisolone dose before you start your procedure. Or you just give the patient injection hydrocortisone 25 to 50 milligrams IV pre-op. And of course, monitor blood pressure. Second kind of a situation is when you have an intermediate surgery. That means a surgery which is involving more stress than a single, for example, a single tooth extraction, like multiple extractions or surgery under general anesthesia. Then it's important that in a patient with no previous steroid exposure for the past 12 months, you could consider cover. That means giving them extra steroid before you start the procedure, or test the ACTH simulations, test and see if the patient is able to produce stress hormones on himself or herself, or does he need extra supplementation. In patients who've been taking steroids for the past 12 months, give usual oral steroid dose in the morning, and not or in this case, and give an injection hydrocortisone, preoperative as well as IM 6 hourly for 24 hours. That means you would give them injection hydrocortisone before the procedure as well as follow it up 6 hourly after the procedure for one whole 24-hour period. In patients who are currently on steroid and you have a stressful procedure scheduled, it's important that you double the oral steroid dose and give the patient injection hydrocortisone and then continue normal medication as well. Right, so that's how this table is important for you to plan dental treatment. So for any patient who is on steroid therapy or has been on the steroid therapy or is deemed to required to get steroid therapy, this would be your dental management strategy. Moving on to hematological disorders, bleeding and clotting disorders. Again, we'll be looking at these very superficially, just some important diseases I would be touching on. For example, Polycythemia vera, it's a chronic myeloproliferative disease, hemorrhage, thrombosis, bone marrow dysfunction, increased RBC mass. Oral manifestations would be intraoral erythema, glossitis, edematous gingiva, and spontaneous bleeding. Oral health consideration in these kind of patients would be to first of all control bleeding after there is any dental surgical procedure. Anemia, very common. Oral manifestations, most common one is iron deficiency anemia, would be angular cheilitis, glossitis in the form of atrophy of the filiform, fungiform papillae, pale oral mucosa, could be oral candidiasis, aphthous like ulcers, erythematous mucosa, and burning, typo error there, burning sensation of the mouth. So Plummer-Wilson syndrome, Patterson-Kelly syndrome, or sideropenic dysphagia is a condition where you have the patient has dysphagia, iron deficiency anemia, and upper esophageal webs or strictures. What are the reasons for oral manifestations in iron deficiency anemia? Is because of impaired cellular immunity, deficient bactericidal activities of polymorphonucleosides, and inadequate antibody response and epithelial abnormalities. Let's look at this case here. 77-year-old woman presented with insidious onset of fatigue and burning sensation of the tongue on swallowing food. 6 years earlier, she had undergone a total gastrectomy for early gastric cancer, which was curative. On physical examination, she was pale and had depapillated, smooth, shiny red tongue. with some central fissures, findings that were consistent with diagnosis of megaloblastic anemia. All right. So the laboratory testing revealed cytopenia, white cell count which was about 3,400 per cubic millimeter, hemoglobin level 6.4 grams per deciliter, platelet count is 154,000 per cubic millimeter, macrocytosis with larger cells than usual, and serum B12 deficiency was also lesser than usual, but the normal range is about 160 to 970. So serum folate level was found to be normal. So the patient received a diagnosis of megaloblastic anemia due to vitamin B12 deficiency, and she was treated with intramuscular vitamin B12 and had a complete recovery after approximately 5 months. So what you notice here is that the dental findings sometimes lead to the diagnosis of the disease. So that is what is the importance of this case. In G6PD deficiency, we would see it's an X-linked hemolytic anemia. Males are affected primarily, and the oral health considerations, what is important is prevention of acute hemolysis triggering exposures, example aspirin or chemicals such as naphthalene balls or drugs, antimalarials, sulfonamides, vitamin K, vitamin C, all of these. Oral manifestations should be treated promptly, and the patient should maintain good oral hygiene. Sickle cell anemia, the oral manifestations are radiographic features like step ladder trabeculae, enamel hypomineralization, and calcified canals, increased overjet and overbite, pallor of mucosa, delayed eruption of teeth, especially in children, orofacial and dental pain with no obvious reasons, cortical thinning, and deteriorated bone tissue. So this is a picture which showing you the effect of sickling of cells and how it blocks the blood flow, and the patient ends up having anemia. So the oral health considerations would be antibiotic prophylaxis for children undergoing any dental extractions, or treatment under general anesthesia, or if they're especially and the status is post splenectomy. Maintenance of good oral hygiene, avoid aspirin use, caution during conscious sedation, patient could go into respiratory depression, and avoid long stressful appointments. And preoperative transfusion of blood may be considered prior to general anesthesia in case the patient has a sickle cell crisis. That means suddenly the patient goes into hemolytic anemia. Thalassemia, the radiographic features generally again majoritarily seen in children are spiky shaped teeth with short roots, taurodontism, attenuated lamina dura, large bone marrow spaces, and thin cortex of the mandible. Craniofacial abnormalities could include chipmunk facies, narrow maxilla and mandibular arches, growth retardation. I'm sure all of this would be covered in more detail in orthodontia for you, or in pediatric dentistry. Delayed dental development, increased caries risk, and oral health considerations. Important to note down if the patient has hemoglobin levels below 10 grams per deciliter. This is an example of a chipmunk facies, and the hair on end appearance that is seen on the radiograph. All of this subside once the patient goes into phase of normalcy. So oral health considerations would be again for iron deficiency. Let's go back to iron deficiency anemia, where the patient has low hemoglobin levels, physician consultation prior to any dental treatment. If the hemoglobin is found to be less than 8, then general anesthesia should be avoided. This is a very important number here. 8 grams per deciliter hemoglobin should be avoided. Any treatment under general anesthesia can be avoided. Clinical bleeding has to be taken care of, and impaired wound healing, as well as increased risk of ischemic heart disease. In leukemia, the clinical features are slightly different. Patient has fever, fatigue or malaise, weight loss, joint pains, anemia as well, and mucosal bleeding and petechiae. The oral manifestations seen are common in acute anemias than in chronic cases. Gingival hyperplasia is seen secondary to leukemic infiltration. That means the leukemic cells get accumulated in the gingiva itself, and this could be one of the first oral signs of acute leukemias. In chronic leukemias, the patient can have exfoliative cheilitis, herpes infection, candidiasis, and mucositis. So let's look at a case again. 21-year-old female patient reports to the dental clinic with bleeding upon brushing, swollen gums which do not look good when she smiles. Her friends have been complaining that she has a peculiar bad breath, and sometimes there is bleeding from her gums without any reason. That is spontaneous bleeding. Medical history revealed that she has been experiencing on and off episodes of fever since the last 6 months. She gets tired very easily after work and feels like sleeping most of the time. So this is the gingiva of the patient. You can see it looks erythematous, enlarged, inflamed, and what we call as boggy gingiva. So the oral health considerations in leukemia would be oral hygiene maintenance prior to chemotherapy and during chemotherapy as well. Dental treatment, example, scaling and extraction should be done 1 week prior to the start of the next cycle of chemotherapy, when platelets and neutrophils are restored to near normal levels. So, identification of a patient with bleeding disorders. It's important to take complete history, family history of bleeding, hemostatic abnormalities, spontaneous gingival and mucosal bleeding, epistaxis, easy bruising, prolonged bleeding from superficial cuts, and of course lab investigation should be also done. So some of the oral manifestations of bleeding disorders, like for example platelet deficiency, thrombocytopenia. Patient could have petechiae and ecchymosis even in the oral cavity. Spontaneous gingival bleeding and enlargement. Brown stained teeth because of prolonged bleeding from the gums, which leads to deposition of hemosiderin on the teeth. In hemophilia, patients may have many episodes of oral bleeding spontaneously, and hemarthrosis is the term used in weight-bearing joints where there is blood accumulation in the joints itself. Whereas this, again, considering the TMJ is a joint, but hemarthrosis in the TMJ is very, very rare. So this is example of petechiae and ecchymosis occurring due to bleeding disorders. So dental management of a patient with bleeding disorders. Mild coagulopathies, when it's like mild thrombocytopenia or mild disorders, only minor dental modifications need to be done. When significant bleeding is expected, a replacement of exogenous source, like example replacement of factor 8 in hemophilia patient, may need to be considered. And also it is very important that treatment should be done only after consulting the hematologist, so that any precaution that needs to be taken is to be followed. The last part of this chapter would be about diabetes, right? And that is a major disease in itself, and a lot of discussion in this area. So this poster here tells you that diabetes doesn't discriminate young, old, rich, poor, man or woman. So Malaysia is expected to have the highest rate of diabetes in the region, and by 2020, that is where we are right now, it's predicted that there will be 4.5 million diabetics in Malaysia above the age of 18, which is not a very good indicator. So a study done by Ministry of Health revealed that 1 out of 5 people above the age of 30 suffer from diabetes, and 2.6 million Malaysians have diabetes, which is more than double the number within the last decade itself, and half of them went undiagnosed. So the World Diabetes Day is 14th of November, and this is a website which you can visit, get more information from here. So the diagnostic criteria for diabetes, this is very important to note, would be hemoglobin, that is HbA1c, right? Glycosylated hemoglobin greater than 6.5%, and fasting blood glucose level greater than 126 milligram per deciliter, or what we call as 7 millimoles per liter. Fasting is defined as no calorie intake for at least 8 hours. The 2-hour plasma glucose level should not be anything greater than 200 milligrams per deciliter or 11 millimoles per liter during the oral glucose tolerance test is considered as diabetes, and the test should be performed as described by the WHO using glucose load containing equivalent of 75 grams anhydrous glucose dissolved in water. Or in a patient with classic symptoms of hypoglycemia or hypoglycemic crisis, a random plasma glucose level is also greater than 200 milligrams per deciliter, that is 11 millimoles per liter. So any of these criteria and the patient is considered as diabetes. Right, so the key numbers that you need to remember here is HbA1c greater than 6.5, fasting blood glucose greater than 7 millimoles per liter, and oral GTT or random blood glucose greater than 11 millimole per liter. So the oral manifestations of diabetes would be burning mouth, also oral dysesthesia, altered wound healing, infections, especially acute pseudomembranous candidiasis or dentoalveolar abscesses, patients experiencing many episodes of abscesses in the oral cavity, especially periodontal abscesses, xerostomia due to medication, silidinitis, bilateral salivary gland enlargements, high caries incidence due to increased glucose in gingival clavicular fluids, and the existence of xerostomia and presence of dental plaque, all of these put together. Gingivitis and periodontitis, poor glycemic control causes progressive destructive periodontitis, and we are very well familiar with the link between periodontitis and diabetes. This is just an example of a radiographic example of how extensive bone loss is seen in this molar here, where furcation involvement is there and arc-shaped bone loss is there, and considerable amount of bone defect is seen. Well-controlled diabetics, the dental management should not be a problem and should be considered as normal, and any treatment should be normally done. In patients, response to dental treatment primarily depends upon the guy's glycemic control. If he's a controlled diabetic, then you can treat the patient as normal. And commitment to medical problems, diet, oral hygiene, and the presence of excessive smoking and alcoholism. So all of these factors combined together would determine how well your patient responds to dental treatment that you're providing. So the steps would be in treating a dental patient who is diabetic would be determine the type of diabetes first of all, and the level of control and medication. So now this is very important to note. Many a times students forget to ask what medication the patient is taking for diabetes. So it's important to note that whether they are only on diet modification or diet control, are they taking oral hypoglycemics, are they taking insulin, if they're taking insulin, how much insulin, and are they on combination. It's important to measure blood glucose meter, so a glucometer should always be kept handy. Consultation with patient's physician if required, and antibiotic prophylaxis if the HbA1c level is greater than 11 to 12, which is quite high, and also to minimize the risk of hypoglycemia in the dental setup. So all in all, the best time to perform dental treatment and reduce stress is just before or after the peak of insulin activity. So that means either is just before the patient is going to take his insulin or just after he's taken his insulin. So risk of hypoglycemia is more definitely with patients who are insulin users. So this is just a gist of how you should manage hypoglycemia in dental office. If the patient is awake and able to take food by mouth, then the best treatment when the patient is feeling hypoglycemic in your dental setup would be just give 15 milligrams of carbohydrate, which could be just a small juice box, or 3 to 4 tablespoons of soda, or hard candy, or some cake frosting. I know it's difficult to find cake frosting in the clinic, but the others are usually available. If the patient is unable to take food by mouth and there's no IV line in place, then 1 milligram of glucagon subcutaneously or IM at any body site is recommended. If patient is unable to take food by mouth and IV line is in place, that means the patient is in a hospital setting, then 25 to 30 ml of dextrose, 50% dextrose solution, or 1 milligram of glucagon would be the best treatment for the patient. So this is just another picture, and that's the end of this lecture series, and I'll leave you with this poster saying that diabetes doesn't discriminate. So we've looked at the most important parts, touched on the most important parts. The rest you need to read up from the textbook, and I hope this lecture serves as as an outline for you to understand how to answer questions and how to go about management of dental patients with systemic health considerations. Thank you.